been a great friend of mine for so many years. He has done his 3-year law degree from Mumbai University. He's in practice for last 20 years, and his principal areas of practice are medical legal law, intellectual property. And he is first type of medical legal in medical legal laws somewhere in 2008, and has been forward several guidelines to be implemented in municipal run, semi-government, government hospitals all over Maharashtra. And Amit was one of the people who challenged the Medical Termination of Pregnancy Act 1971 through FOXI. And so we have got all the amendments thanks to many efforts by all of us, and Amit was one of them. So invite Advocate Amit Karkhanis for his talk.
Let me apologize to my co-speakers that I jumped the queue. I'm sorry because I requested the host team that I may be allowed because I have to travel back to Mumbai. There is a wedding in our family. It's a wedding season. Yesterday also we saw here. So first and foremost, Dr. Milind Shah, great event. Dr. Monica, wherever she is, one-man army. I think so she is the only army here. So when I requested Monica that Mala zara thoda adi ghe, she just told the host, just start with him. So I told them that, see, this is how Modi functions. And what you were trying to do is a democracy. Okay, we need a combination of both. And Solapur Obstetric and Gynec Society requires Milind Shah and Monica also. And the entire team is beautiful, good host. And I think so, Dr. Milind Shah, I've known you for years, but I've never got an opportunity to speak at events that you have organized. This is the first time, and that too with such a beautiful topic. Normally, I get to speak on PCP, NDT, MTP, ART, so is big time now. ART, surrogacy, whatever, legal notice. But when I met him at the presidential conference in Mumbai, I asked him that, are you going to invite me for a panel discussion? Because I'm not going to travel to Solapur only to answer 2 questions in a panel discussion. He said, no, I'll give you dedicated presentation, and this is a topic I want you to talk on. And I immediately said yes, because I think so it is a very challenging topic, even for a lawyer. Because at the end of the day, this word fetus must be hounding you, bothering you, or it must be coming across to you every day in your practice. You deal with this. And while digging deep, while deep diving into this topic, thanks to Dr. Milind Shah's request, I came across some very interesting, facts about how the legal system in India treats fetus. It is very heartening. It is not disturbing for you. Let me assure you at the outset. The legal status of a fetus is mostly looked at by the court from the MTP point of view. Okay, so the law of MTP is very much clear. We have an amended law now, and there are a lot of judgments also about, when the law was in the process of getting amended. You saw contributions of Dr. Nikhil Datar and everyone who tirelessly fought, for getting that 24 weeks. I was part of it in the earlier stages while we challenged that Nikita Mehta's case for the first time, basically. And then subsequently the Supreme Court also, set up a committee, and then fortunately the law of the land is now there. And thanks to the efforts put in by FOXI also, PCPNDT also we challenged. Obviously we had a mixed response there, but nevertheless our voice was being heard. And what we managed to do is dilute the harassment that was being meted out to the gynecologist, at least in the state of Maharashtra. And I just played a very small role in that, but I was very happy to, fight those cases. As far as fetus is concerned, one has to look at it from the legal point of view. I'm not going to look at it from the medical point of view. That's not my job. That's your job. But at the end of the day, if this is bothering you in your day-to-day practice, I think so you should look at it also from the legal point of view, because as far as law is concerned, the Indian law really doesn't give a status of humanhood or as a parent, as a live this thing to the fetus. It is normally, around 24 weeks, 28 weeks, what is looked at is when the fetus will survive outside, and how viable it will be. So, personhood is not given under the Indian law. There are some exceptions, but broadly speaking, Indian law generally doesn't grant fetus independent parenthood or rights. It is considered an extension of mother's until birth. So, what is looked at is the mother's right and not the unborn child's rights. Obviously, there are some exceptions in Indian laws also. Now, as far as inheritance is concerned, there are some laws in India like Transfer of Properties Act where you can transfer a property in the name of an unborn child, but that transfer will come into effect once the child is born. There are exceptions, but those are only limited to property related, inheritance related. Criminal law has some provisions. Obviously, MTP is an exception to criminal law. MTP came as a protection to doctors. Because if you read the old Indian Penal Code, it makes it an offense to terminate a baby without a consent of the mother. So, what happens to a doctor who does it for the medical reasons? So that's why the Medical Termination of Pregnancy Act was enacted by the government to protect the doctors and give them a legitimate reason to do MTP. So MTP ke liye to obviously there is abortion laws, and very, very limited extent they give right to an unborn child. So per se the rights are not, absolute rights. There are limited rights. Now, obviously, these are some of the provisions of the Bharatiya Nyaya Sanhita, erstwhile Indian Penal Code. Now, obviously, we have changed names. Even I can't pronounce them so easily. They're all, Hindi-speaking names, so to say. And I find it very difficult. But this is a common, Bharatiya Nyaya Sanhita is fine. But if you see CRPC and Evidence Act, my God, this is awesome. No. So these are some of the sections. So section 91 is important, punishes act intended to prevent a child from being born alive or causing death after birth. Section 92 punishes causing the death of a quick unborn child through an act of culpable homicide. These are the things which are actually dealing with the fetuses, means of an unborn child. Obviously, there is section 90 and 90.1 and 90.2, but those are relating to consents and those are relating to women per se. But obviously, it relates to pregnant women. So, when you talk about pregnant woman, you automatically have to consider the child part of the pregnant woman. Okay, so that's why these sections become important. But section 91 and 92 are directly related to the right of a fetus to be born. Okay, means it should not be harmed in any manner. Obviously, that's why you have exception of medical termination, that in the interest of woman or in the case of medical emergencies to save the life of the woman, failure of contraception or whatever. There are guidelines laid down in MTP also, which obviously we will see. These are 3 or 4 acts where actually there is a reference directly of some sort of a right to an unborn child. Obviously, these are not related to you. These are not related to medical practice, but it is good to know. Because normally what happens is, when there are pregnancies in big families, rich families, big families, inheritance becomes a very big issue at times. Okay, so it's always better to know when. Section 13 allows a property to be transferred in the name of an unborn child, with the transfer becoming active only after live birth. So if the birth doesn't take place, then obviously that transfer doesn't take place. Section 20 of the TOP says that treats unborn children as living for property related purpose. So for property related purpose, yes, the unborn child can have some sort of a legal right, but that child can enjoy that right only once the child is born. Hindu Succession Act is an act which is applicable only to Hindus. It is applicable to Hindus, Jains, Sikhs and Buddhists. These are the 4 religions which are covered under Hindu Succession Act. For Mohammedans and Christians, there are different acts. There is an Indian Succession Act for Christians, Parsis, and Jews, and for Muslims there is every discipline has a different succession act. If you are a Shia, you have a different act. If you are a Sunni, you have a different act. And Sharia is there. Obviously, in India, Sharia law is also applicable to some extent. Hindu Succession Act, a child conceived at the time of an intestate's death but born alive has the same inheritance right as it is born before the intestate's death, with inheritance deemed to be waste from death, the date of the death. What intestate means is a person who dies without a will, a person who makes a will and person who doesn't make the will. So the right of an unborn child under the Hindu Succession Act, if that person has died at the time of death, the right of a child starts from the date of the death. Limitation Act is there. Now this is important because many a times I get asked that can a child sue me after 18 years? है कि नहीं? आपको भी पूछते होंगे. You also must be getting this question so many times that I delivered a baby 18 years back. And now the baby says that there is a scar on my head. While delivering, you didn't deliver it properly. And what if there is a girl, a very pretty looking girl, who wants to do career in acting, and if there is a scar on her face? You never know. So there is the Limitation Act. And Limitation Act is very confusing at times. So this says, Section 6 says, unborn children are included under minor for legal purpose such as property claims or inheritance, allowing legal remedies after birth. So Section 6 of the Limitation Act makes it very clear that a child can sue at the age of majority after 18 for the acts done while the children are minor only when it comes to property or inheritance. मेडिको लीगल के लिए नहीं. So please don't get psyched because of this. There is absolutely no reason, and I deliberately emphasizing on this Limitation Act is because Limitation Act is a separate act which actually deals with when you can file a case. In the Consumer Protection Act, the limitation is for 2 years. Right? 2 years from the date of cause of action. Which means that the day the patient comes to know that I have suffered an injury, from that date till 2 years he has a time or she has a time to go and file a case in the Consumer Protection Act. But Limitation Act is overriding everything in India because it's a special statute. As a special statute dealing only with the limitation for all the cases, it says very clearly that it can be done by a person. So if tomorrow you deliver a child and if the parents have, are trying to accuse you of wrongly delivering it, or they are accusing you of some medical negligence, then you don't have to worry about that because the Limitation Act will immediately come into play. Now all these things is easier said for me, but they need to be pleaded. So nothing stops the patient, madam, from going to the court because we don't have a barrier at the entry point. For purpose of harassment, त्रास द्यायला कोणीही काही करू शकतं इंडियामध्ये. है की नाही? You cannot stop a person. You can see that the cases have been filed against Prime Minister, President. It's a different thing that those cases don't go forward because there are provisions later on. But to begin with, they can harass you. That's why Limitation Act is there. You have to take this plea of limitation immediately when you come to know that this is a time bar case. So that your lawyer will have to do, and you will have to have a good legal team, and you need to be alert, and then only you will be able to plead this defense. So it's a very solid defense. There are umpteen number of judgments of the Supreme Court which says that the limitation should be taken seriously. As recently as last week, Supreme Court has reiterated that delay should not be allowed, delay should not be ignored, and unless you give a plausible explanation for the delay should not be condoned by any court in this country. So they have re-emphasized it, and they have emphasized it very, very strongly. Constitutional, now let's come to the Constitution. Article 21 talks about right to life. Now this word right to life is so broad that it encompasses everything under it. Now, the first time Supreme Court expanded the scope of right to life in Karkhanis case, where it says that the interpreted right to life to include the right to live with dignity, extending protection to maternal health and indirectly benefiting the unborn child. Then in Unnikrishnan's case, also the Supreme Court said that the right to life was expanded to include access to medical care, safeguarding both maternal and fetal health. So right to life slowly has got broader meaning. So right to life also includes right to good road. Because you travel on bad road, you break your back. Our orthopedic friends are very happy. But at the end of the day, what you are expecting of a quality of life is right to life. So right to life has been expanded over the years. Even every day there is a judgment which comes on right to life. So even in Suchita Srivastav's case, Supreme Court acknowledged the unborn child's right to life. But now this is important. But emphasize that this right is not absolute and must be balanced with mother's reproductive autonomy and state regulation. So what you must understand is that mother's autonomy is more important than the unborn child's rights. So don't worry about the rights that the unborn child will have. Worry about the mother who is lying in front of you. That is what even the Supreme Court expects from you. And you are doing that. None of you are actually, saying, "Arey wo bacche ke andar ke bacche ka kya hoga?" Obviously, you have a priority is the mother. You need to save the mother, and the best case scenario is saving both the people. Right? Mother bhi khush, bachcha bhi khush, sagres khush. So from at the end of, what matters is that Supreme Court recognizes that there is definitely not an absolute right. So, what will happen once the child is born should not be on your minds. That is my message to you. Very clearly, emphatically, and absolutely is that you don't have to worry about what the child would think. What the mother would suffer or the mother would think is more concerning for you than the child. So what you should worry more is about what mothers who is getting treated under you are feeling or how they are doing. Or if there is any problem, you should focus more on the mother's issue than the child's issue. That is what it says. Now, obviously, right to full development and sex selection, abortion, I don't have to tell you, we have PCPNDT Act, it was enacted basically to prevent sex selection and everything. So obviously under Article 21, right to life, it also says right to full development. So it has been interpreted in various judgments in the last 3-4 years. Unborn child has a right to full development under Article 21, right to life and personal liberty akin to the right, such access of clean air, water and reasonable housing. The right protects the unborn from harmful practices such as sex selection, abortion. So obviously these things are, these are the fundamental rights. These are all, on paper, whether a child was subjected to a sex determination or no, it is very difficult to prove in the court of law. But nevertheless, you see, we follow in India a legal system where everything has to be proven. We are living in a civilized society. We follow rule of law. What rule of law means is that whatever you say, whatever you accuse, you need to prove it. Just because the patient is saying something doesn't make that person true. So if someone accuses you and you know that he is wrong or she is wrong, don't worry. He has to prove that. Just yesterday I won a case. Before coming here, I was appearing in Bhopal online against a very big hospital in Mumbai. So the judge asked the same question to the complainant. You have spoken for 2 hours. I have heard you. Show me a single paper that you are proving what you are saying. Don't tell me what happened which is not on paper. Show me the evidence. Because Mr. Karkhanis, who is appearing, has given 5 judgments of the Honorable Supreme Court which says that when a complaint is filed in a consumer court, it is a complainant who has to prove medical negligence by way of an evidence. Show me the evidence. वो जेरी मगवायर एक मूवी था टॉम क्रूज का, in that there was a famous dialogue, show me the money. right? That black sportsman used to always tell Jerry, who was played by Tom Cruise, show me the money, show me the money. The same way we lawyers always say, show me the evidence. So I kept on telling the judge, let them show the evidence, I will respond. I didn't argue that case on facts because there was no requirement. I tendered 5 judgments of the Honorable Supreme Court. And I told the Honorable Judge that now, after reading these judgments, you see the complaint and what the complaint has filed. If you are satisfied that he has filed a complaint as per the Supreme Court norms, then I am willing to argue this matter. Otherwise, you are wasting my time and you are wasting your time. She took my advice. Obviously, the case is over now, and I am confident that we will win the case. Because ultimately, we need to be supported by evidence everywhere. So, evidence hai to sab kuch hai. Now, obviously, the law has to always balance the right of the woman's autonomy. अरे झालं रे बाळा हे काढ. 2-3 स्लाइड्स आहेत बस झालं. मुंबईवरनं आलो जरा 2 मिनिटं एक्स्ट्रा दे. जरा ट्रॅफिक लागतो ना आम्हाला लोकांना म्हणून जरा उशिरा संपायची सवय आहे. So medical termination of pregnancy act is there. There are all conditions that I don't need to take. You are all masters of MTP and PCP NDT. But obviously MTP is giving a woman a right to choose what she wants to do. This is also part of Article 21, right to life. Even in Nikita Mehta's case, at one point the court had passed an order. Justice J.N. Patel was there from Nagpur. He very clearly told the state government that, see, we are not going to go beyond what the mother wants. Unfortunately, in the course of the hearing, he retired. So the new judge came. And the new judge was very conservative. He was from Goa. I don't want to take names. But he was from Goa and he did not accept our contention. How I wished Justice J.N. Patel would have continued and we would have actually got a relief in Bombay High Court itself. But he made a very bold statement, that it is the mother who will decide what has to be done. And in this case, if this woman doesn't want this child for various reasons, I am not going to ask her why. Let her decide. All your feelings, तभी तो कांग्रेस का government था. We didn't have sanskari government. I'm not against this government, don't get me wrong, but a lot of things happened due to some, religious undertones also. Even in Christianity, if you see America, they have scrapped the abortion law. Now it is up to the state governments to allow or no. It's very difficult to abort a child in America now. Teenage pregnancy is a very big problem. So that's why it is extremely important to know that religion plays a very important role in deciding the issue of abortion. And it is an election issue in America. And Trump won on that issue. The liberals lost. So that's why you can see where we are heading. And I don't think so we are as bad as America. We are much forward. We have an MTP Act, which is neutral, which is applicable to every Indian woman, irrespective of her religion and caste and whatever. We are way, way advanced than America. They may have a good education system, but their courts. For example, domestic violence है ही नहीं अमेरिका में. Husband can beat the wife, and they tell the police will just call the husband, warn them. They don't have domestic violence. A mother can take the child without father's consent. Father can take the child without mother's consent. Police will say, it's all domestic issues. We have no provisions in any law to punish you. Imagine such situation in India. अगर कोई wife को धोता है, तो आज newspaper में आता है. Our system is much more robust, basically. So fetal viability is more important for us to understand, because law accepts only that. And most of the legal terms are basically, our decisions are based on this term, and obviously abortion issues are also related to this. Just take one judgment or 2 judgments at the most, I'm done. Now, courts ruling, the Kerala High Court dismisses the petition for termination, ruling that the right of the unborn child must take precedence when there is no threat to the mother's life or health. So like I mentioned, courts have always linked the right of a child with the health of the mother. So, and in most of these judgments, there are 2 or 3 more judgments, they are all germinating out of MTP. So, right legal status or legal reality of fetus as a patient is actually a notional concept, which means that it is not there as such, but it is linked with the mother. So if the mother is good, if the mother is doing right, and if everything is going on well, then I don't think so we should worry about fetus or the legal status of the fetus. This is also another case which was, in 2024. The minor was 26, petition was filed by the uncle of a 16-year-old. It was a rape case basically. The court noted that the pregnancy had exceeded the 24 weeks limit and the termination beyond this period was not permissible under the law. The court emphasized that termination of this stage could be considered foeticide. Now this, most the judges of the courts are also, sometimes very unreasonable in using terms. We had a very bad experience of one gynecological case coming from Ratnagiri district. I think so you all must be knowing that case. I took the bail for them in the Supreme Court. Husband and wife doing a great service in rural area. Very pious people, very, very good people. Dr. Shah, you must be knowing these people. And the kind of references which were made by the Bombay High Court, a lady judge, Sadhna Jadhav, I am appearing before her as an arbitrator, now she is appearing in my matter. So once I met her for that arbitration over a tea, I told her, Madam, your reference in that judgment was unwanted. All the doctors are there to make money. And that's why why did you take that patient in your hospital? You were money minded. That's what she said in the court. The lawyer was not able to convince that she had told the patient not to get admitted in my hospital. She said, I am here for a CME in Pune, which was held in Westin, and me and my husband are here. We are not there, but Kulkarni is there. His hospital is running fully. He is a gynecologist. You please go and get admitted there. The fellow was over smart. The husband of the woman who died, over smart. Journalist tha na. जी 24 तास में था. He had everyone in his pocket. In that small district, everything is, the journalist, policemen are kings. They can do anything. So that journalist pressurized people, and then ultimately the medical board gave a wrong opinion. The district court did not entertain for anticipatory bail. Wrong sections were applied. Sections which the Supreme Court in Jacob Matthews case said cannot be applied were applied. Unfortunately, the session judge did not even look at that. They came to the High Court. High Court was furious on them for admitting the patient. They went on a different tangent, made such statements which were unwanted. Every judge makes a statement. And then ultimately the High Court rejected. Then they came to me. After that, fortunately in the Supreme Court we had a wonderful bench of Justice Lalit, who hails from Solapur, by the way. A great man. Great man. Solapur has given best judges, A.P. Shah, who decriminalized homosexuality in India for the first time. Ajit Shah is from Solapur. Great people. Bhimrao Naik was also there as a judge of the Bombay High Court. And Justice Lalit ultimately asked the state, Ki, what are you doing? Like, have they run away anywhere? Why are you hounding them? They gave the bail, and then obviously now the trial is on. I'm not involved in that case. My role was only to get them out because they were underground, literally underground for a month. Husband, wife, maybe 55, 60 years old, on almost on the verge of retirement. Means this is not the thing that you do as a judge of the high courts. And that's why sensitizing the judiciary is also very important. So as part of SOGS, if you ever get an opportunity to invite a consumer forum judge or a session judge, like you invited yesterday the police commissioner, start inviting these judges. Let them sit with you, grow with you, and understand what is fetal medicine, what is gynecology, what it takes to deliver a woman. Let them see your pain. And then only they will start passing good orders. So that's why, this judgment I'm not very excited or happy to show you. But at the end of the day, this is a judgment which was passed by a competent court. And this is a Supreme Court judgment which just recently came, and this is the last slide. 20-year-old unmarried woman filed a petition seeking termination of a pregnancy which had exceeded 30 weeks. She discovered pregnancy at 27 weeks and sought an abortion, citing physical and mental health risk related to preparing for NEET exams. Court ruling, the Supreme Court emphasized that the petitioner did not fall within the legal exception for extending the abortion deadline. Court highlighted that the fundamental right of the unborn child to live, which overweighed the petition's request. MTP Act pregnancy limitation case highlights the strict limitation under MTP Act, which does not allow termination beyond 24 weeks unless specific condition like subnatal fetal abnormalities or risks to the mother's life are met. So this is a very latest judgment which actually again emphasizes the right of an unborn child, but vis-a-vis abortion. So if you have a case like the predecessor speaker from Wadia, from Mumbai, sorry, she mentioned about cases that they had filed, and she had spoken to me also a couple of times. So when you are dealing with abortion, that is a time when you have to actually start thinking about this. Till such time, I don't think so you need to worry much about this. And with this, I would like to end my session. A very sincere thanks to Dr. Milind Shah, Dr. Monica, Solapur Obstetric and Gynec Society, all the office bearers, and a wonderful host that you are, Dr. Milind Shah. And I wish you all the best for your endeavor. And Foxy deserves you, and you deserve to be the president. And another star should be born from Solapur. Thank you very much.
Thank you, Amit. Now I invite on stage.
I would request Dr. Milind Shah sir, Dr. Neeta Ghate ma'am, and all the chairpersons to kindly felicitate Dr. Advocate Amit Karkhanis sir, since he's in a hurry.
Yeah. Amit, thank you for all those enlightening things. That Transfer of Property Act is only available. And one small question I have for you. Yeah. The last question is, MTP Act is for all Indian citizens. Now we have a lot of medical tourism also.
Yes.
So can a person who is not an Indian citizen come to India and get MTP done?
I'll tell you. It's a good question. I'll tell you both the sides. When an Indian goes abroad and when a foreigner comes to India, it's very important. Because, see, when you read the first line of an act, what it says, this act is applicable to the whole of India, right? Which means that it covers the entire territory. Now even Jammu Kashmir se leke Kanyakumari tak. First it's to exclude the state of Jammu Kashmir, which was very painful at that time. As an Indian, true Indian, I used to feel very pained that why Jammu Kashmir feels separate. So now everything is included right from Jammu and Kashmir, so that covers the territory. Now the second line, if you see, this act is applicable to citizens of India. So which means that whenever you travel abroad, for the acts done by a citizens abroad, you can still be held liable here. So which means if you do an illegal termination, or if you do sex determination in Dubai, or if you do sex determination in Thailand, or even on a ship on whatever high seas, whatever nowadays, so many rumors are floating, yahan pe hota hai, wahan pe hota hai, all this, kahin pe bhi hoga. If they come to know, and if there are evidence, then the government can file a case against you. Now, as far as foreigner coming to India is concerned, whenever they come to India, whoever is there in India, all the Indian laws are applicable to them, including fundamental rights. So a foreigner can also claim right to life under Article 21. Because they are in India, they have an Indian visa, they will have to come on a medical visa. If they are coming for treatment, you cannot treat anyone on a tourist visa. You have to tell them to come on a medical visa. Your clinic's name is also mentioned on the medical visa. They give you an attendant visa also, if you have a husband or wife coming with you for a treatment. And when they come for a treatment, when they subject themselves to Indian hospitals or doctors, at that point of time, all the laws which are applicable to an Indian citizen are applicable to them. They can sue you like an Indian citizen for medical negligence also. So which I am doing for a dentist in Mumbai. She had come from US for implants. The doctor was in Taddev, Mumbai, happened to be a friend of mine, both husband-wife dentist. She came and they literally goofed up there. And she went back there, she hired a lawyer here, and he filed a case against them and defending them for last 5 years now. So such things have happened and are happening on day-to-day basis.
No, what my question is, if a person comes here as around 18 weeks, as anomaly, is a resident of some country where MTP is not allowed and wants to get MTP done in India when she comes, will it be legal for us to offer her termination?
If she is falling within the MTP Act's parameters, yes.
Okay. She may be sued for that in her country, but
So
here
what
we can do.
what happens to her in her country is not our lookout.
Okay.
But in India, you are protected and you are allowed to do it up to 24 weeks for the reasons mentioned in the Act. You can do it, no one can touch you here in India.
Thank you for that clarification. It was addition to my knowledge. Thank you.
No, thank you very much.
Thank you very much, Amit. Friends, you know that there is an International Society of Fetus as a Patient. So when this concept came to us, I thought let's have a conference on that. And you know Dr. Asim Kurzak. We met him actually in one of the WAPM conference when my daughter Naval had presented a paper and got a best paper award. Of course, creditable to Dr. Vidya Tirankar, who used her neonatal scoring and gave her guidance to present that paper as well. So I wrote to him that whether we can endorse this conference by your society so that, you know, we'll learn little more from you as well. But Asim was a little busy and he said, okay, I cannot come for the online as well for the inauguration because of some reason. But that time the question came to my mind, whether fetus is really a patient.
Yeah.
So then I called first Nikhil, because he does a lot of work on the medical. So Nikhil said, no, fetus cannot be a patient. And then I said, it was so incidental that I met Amit. I said, Amit, you'll have to come to Sholapur now. And Amit is a foxy lawyer, we always say about whenever we get
Nikhil's
some
Nikhil's daughter's reception is there on
yes,
his
both
mind.
daughter and son, both are
Yes.
getting married on 11th and 24th.
Yeah.
So then I requested Amit and he immediately considered not only Amit, Mrs. Karkhanis is also very much here and she has brought that OM becomes a simulator. So please all of you try that during lunchtime. They have
So we have a simulator, computer based. You can go and see in the next room. You will feel so good. You know, this is a make in India, made in India, completely Indian product which looks world class. You can feel that, you can take the feel. If your medical students are here, they all can go and see and feel the, product because, it is like like a pilot gets trained on a simulator. It's the same feeling that you get. Okay, so please try, leave your feedback. We can improvise on that simulator if required and let us know and leave your numbers please so that we can call you and take your feedback.
So we also want to felicitate her because just in 15 days notice she said, yes, I want to come to Sholapur, we want to have the stall as well and it's really wonderful to bring that simulator. So thank you very much, yeah. She also now started a new venture of establishing IVF setup. So all of you who want to start IVF center, she will be of extreme actually help to you for all the necessary arrangements. So you want to say anything on that?
So if anyone wants to set up IVF labs, please do contact us. So on that our simulator counter we have cards, please take those and if you wanted to set up then please call us and contact us. Thank you.
Yes, thank you. Yes, I know. Yeah. Thank you very much, Ami. Thank you. Definitely pleasure. Yeah, thank you.
Thank you, sir. Next speaker in this session is Dr. Shetal Mehta. Thank you. Thank you. Dr. Shetal Mehta. She has done fellowship in fetal medicine from Mediscan, Chennai. She is ex-assistant professor from KEM Hospital, Mumbai. She has research fellowship done from Fetal Medicine Unit, Department of Maternal and Fetal Medicine, Sick Kids Hospital, Toronto, Canada. Welcome, ma'am. Start.
Yes. Hi, thank you everyone. First of all, thank you sir, Dr. Milincha, Monica for the invite. And thank you everybody. It's a Sunday morning and I'm sure we are very hungry. So thank you for staying around and I'll do my best to do good justice to the time that you're spending listening to me. So I've been to, can't see. Acha. Escape. एक मिनट इधर। Okay, perfect. So let's begin with the kind of scan reports that all of us see often. We see a report of which describes it's a single life gestation, cardiac activity present, fetal activity present, placenta is fine, Liker is normal, and these are the growth parameters with the final line saying that the weight is 1.1 kilo, 27 weeks, 2 days, and EDD according to this scan is 6th of February, and one line mentioning the anatomy. Now my question is, are we happy with this report? Is this all? And if you're not happy, what is missing? And what do we do to supplement this? So the most important thing is, the one take-home message which needs to be taken is, you cannot exchange gestational age for growth. Weeks are meant to tell you how old the fetus is. It's not meant to tell you the weight, whether or not the baby is growing properly. So no growth scan report is complete if we do not establish what is the age of the fetus. Only if we know the age will I be able to comment if the growth is okay or not. So this report obviously is lacking, and what I would request is to move from looking at weeks and weeks lag as far as growth is concerned to looking at centiles, because it's a lot more standardized form. We have a lot more defined endpoints. So the other thing I would like to everybody to take home too is, please start looking at centiles as far as growth is concerned, and to not accept report if the report doesn't comment if what they think is the growth compared to how much older the fetus needs to be. So FGR itself has a lot of conundrums. So the definition of FGR says it's the failure of a fetus to achieve its entire growth potential. And just the line is very ambiguous. It's not going to be possible for you and me to know what the potential of the fetus is to grow. To add to that, what cutoff do we use? There were various papers over the years which have used different cutoffs for defining a baby as small. Less than third, less than fifth, less than 10th, what do we take? And then how do we decide these centiles? Depending upon what growth chart you do, the same weight is at a different centile. Hadlock chart is what charts are available on the machine. They are old, they are retrospective. There are many other charts available now. There's the Intergrowth chart, there's the FMF chart. In the same city of London, 2 big institutes are using different charts to chart the growth of the fetuses which are in London. So there's a lot of controversy, and then there is all about population specific chart. We are Indians, our babies are smaller. Should we apply those charts to our babies? So there's a lot of questions and unfortunately no clear answers. And then, are all small babies necessarily growth restriction? And the answer is no. All the small babies, there is a small part, or I would say an equal half part where the babies are small but healthy, which we call as SGA. On the other hand, do all growth restriction babies have to be small? What I'm trying to say is, all growth restriction babies are not necessarily less than 10 centile. If a baby's weight is 20 centile, that might still be growth restriction for that baby because its potential should have been to reach 80 centile. So these are a lot of unclarities in growth restriction which we still don't have the tools to answer. Having addressed these, what we'll try to do is try to see if we can get some clear-cut outlines or protocols that we can follow for ourselves to the best, which is what best we can do in such situation. So to begin with, one of the most universally accepted definitions where we start calling a fetus small is either the abdominal circumference or estimated weight less than 10 centile. Most papers now universally have accepted this. So that's like one point in our favor, that we begin investigation when either the AC or the weight is less than 10 centile. Once that happens, what's the next step? First, go back and confirm the dating. A lot of this should happen naturally, but at times you get reports where it's not done. So as obstetricians, probably what we need to do is check the dates as according to the first scan and first rule out any wrong dating. Once you give the EDD, it stays the same, no confusion. Second, Once we've confirmed that indeed the fetus is less than the 10th centile, have a look at the anatomy. Is the baby structurally normal or not? Is there any signs that there could be aneuploidy infection or whatever? And then you switch on Doppler so that we get more information about that small baby. So what we're basically trying to do is trying to differentiate a constitutionally small and a healthy small baby versus a growth restricted baby. What we'll also obviously know is if it is growth restricted, is it early or late, and how severe is the growth restriction, and obviously how much do we follow up, when to deliver. 28 weeks abstinent flow, should I wait, should I deliver? 30 weeks abstinent flow, now what do I do? It's reversal at 27 weeks, what do I do? So it cannot be instinctive. These decisions cannot be case basis. There has to be a protocol which you have to follow so that you get consistent reports. Now why differentiate? 10 centile head, 2 kg baby at 36 weeks. Why should it matter if it's a SGA baby or a growth restriction baby? 36 weeks head, 2 kilos head, why should it matter? Because it has been proven that for constitutionally small healthy babies, adverse perinatal outcome is much, much lower compared to growth restricted babies. Those growth restricted babies are simply starving. They need more attention, and we definitely need to differentiate between the two. And another point, when we say early versus late, it is not the same as symmetric versus asymmetric. That's an old concept. We no longer describe babies as having either a symmetric or an asymmetric IUGR. There's an overlap in phenotypes in every ways. And at the same time, it cannot tell you, so not all early growth restricted babies are going to be genetic, like all genetic abnormalities do not only cause early growth restrict. We have cases of Down syndrome where they have sneaked in, and after 32 weeks, we've seen growth restriction with nothing else, and it was Down syndrome, and vice versa. We have seen cases of placental dysfunction, extrinsic cause, which does cause an early onset growth restriction. So the only differentiation we make is early versus late, not the rest of it. And what's the difference between the two groups? Early onset is very easy to diagnose. It's staring in your face. There is a severe placental dysfunction. Mother usually has preeclampsia. The problem with this group is going to be management. How do we follow them up? When do we deliver? Fortunately, these are less common in the late onset. These babies, because of that chronic restriction, have already had some amount of systemic cardiovascular adaptation, but this group also has a high morbidity and mortality, mainly because of the attendant prematurity involved. Versus late onset, the problem is actually diagnosis. If you don't do a scan, if you're not careful, if you don't switch on Doppler, these are babies we might miss. They're a lot more common, and they do not really have that high proportion of stillbirths. But if you look at the overall proportion of term stillbirths, late growth restriction form a major part. These mothers are not red flags. Mothers might be completely fine. Preeclampsia is not going to come to your aid. A low PAPA is not going to come to your aid. So these babies do not show any systemic, but they show some amount of central adaptation to this hypoxia. So there's a slight change in physiology between both these groups of growth restrictions. And the cutoff universally decided again is 32 weeks. Onset of FGR less than 32 weeks, causing delivery before 34 is early. Onset after 32 weeks is late FGR. Now, before we decide how to apply these Dopplers, just a small quick word about how each of these Dopplers is going to help us reach a decision. So when you look at umbilical artery, another thing, these days all papers only talk of umbilical artery PI. No looking at S/D ratios, no looking at RI, not because it's not going to give you the information, because I'm not going to be able to tell you what centile that particular parameter is going to fall at. So if I want standardization, if I want to be able to give you correct information, we only and only look at PI. So basically, umbilical artery is telling you the resistance that the placenta is offering to the blood flow. And this resistance might increase as the pregnancy advances. And this worsening of resistance, fortunately, in most cases, follows a very set pattern. They'll be increased for a few weeks, after which it becomes absent and then reversed. So there's a pattern which can be used to put to use to form serial monitoring. Because there's a temporal pattern of worsening, you can use this vessel to follow up a baby week after week, and you can also use this blood vessel to plan delivery because it gives you enough of a heads up to deliver. How does it give a heads up? Even when you see an absent or a reversed end diastolic flow, usually the baby is not going to be terminal in the next 1 week at least. What it's telling you is, even when you see an absent or a reverse, provided the ductus venosus is okay, there's no reversal in the ductus. If you see that, then we still have time to cover with steroids, cover with Maxulf, and maybe transport antenatally to a higher center if that is what the baby needs. So we don't really have to jump the gun, especially if you've been following up this baby serially for quite a while. Moving on to the middle cerebral artery, what happens is when there is hypoxia, there is cerebral vasodilatation, decreasing the resistance in the middle cerebral artery. So low PI is a hallmark of growth restriction in the middle peripheral artery. The moment there is hypoxia, yes, these babies generally tend to have a slightly poorer neurological outcome. So the moment you see low PI, you can anticipate that. But what we don't know is, delivering these babies preterm in the anticipation that this is a poor neurological outcome is not going to help. So what I'm trying to say is low PI should not mean that we add the insult of prematurity, because that has not helped the outcomes. What that means at the other end is that middle cerebral artery PI is not going to be of help as far as managing early onset growth restrictions are concerned, because it's not going to tell you to deliver before 32 weeks just for that particular finding. The role of middle cerebral artery PI, however, comes in the late onset. That's another concept which is new. Earlier we thought if the umbilical is normal, we do not need to look at middle cerebral artery. Now there is enough data to say that as an indicator of mild hypoxia, middle cerebral artery PI can be a lot more sensitive than umbilical. So there have been cases of late onset restriction where the umbilical is normal, but the middle cerebral artery PI is low, and we have to pay attention to that. It's a very sensitive marker. So the main role of this particular vessel is in the management of late onset growth restriction. To this MCA PI, if you add instead CPR is a ratio of MCA PI on umbilical PI. So if you use this ratio instead of the PI per se, it's even more sensitive, because the umbilical may be high normal but still normal. The MCA PI might be low normal but still normal. But the moment you do a ratio, the CPR is going to be low. So it picks up even more cases of growth restriction instead of just the middle cerebral artery. So this particular value and vessel is of great importance in managing our late onset ones. So the cutoffs that we use is an MCA PI of more than the 95th centile and a CPR of less than 5th centile, which is abnormal. Moving on to ductus venosus. In the morning we've heard a fantastic lecture about ductus venosus. I'm just going to restrict myself to its use in growth restriction. So we know that the ductus venosus is the vessel which enters the heart. So what it is basically telling you is giving you information about the heart's contractility. So in very severe stages of very prolonged hypoxia, causing myocardial hypoxia and impending cardiac failure, ductus venosus is the vessel which is going to give us that idea that, okay, we need to look further, we need to open our eyes and sit up now, because this vessel is becoming abnormal, indicating an imminent cardiac decomposition. So this worsening also happens in stages. First, the A wave becomes deep and then it reverses. So it is the single strongest parameter to predict short-term fetal death in early onset FGR. Why early? Because in late onset, the adaptation is different and we never wait for things to go this bad in a late onset FGR. So how does the ductus venosus help? If you see a ductus venosus abnormality and in your head, if you think your NICU is going to give you, is going to say, okay, we can salvage this baby, this is the time to deliver. So traditionally, we define viability in a tertiary care NICU as either 600 grams or 26 weeks. This definition does not need to apply to you as is. You have to talk to your neonatologist, find out what weight and what gestation they are comfortable at. Once your fetus has reached that gestation, and after that gestation, if the plan is to give your all for the fetus, then a reversal in the ductus venosus is the time when you rush into deliver. So it also, the changes in this ductus venosus will precede NST changes that we see when we are monitoring, or a change in the BPP also. Finally, the uterine artery, as far as growth restriction is concerned, again, uterine artery, only and only we talk of mean PI. No separate left is normal, right is high, no. Left and right, calculate the PI, find out the mean PI. If the mean PI is more than the 95th centile, that's abnormal. Notch, no notch, doesn't matter. This is the only criteria that matters. This particular vessel has a bigger role in prediction and prevention of placental dysfunction. Its only role in FGR is to help us define whether a small baby is a growth restricted baby or a healthy small for gestational age baby. If the weight is less and if the fetal Dopplers are normal, but if the uterine artery is high, we will call it growth restriction because this is evidence of placental dysfunction, and we will not call it SGA. So once you've established that at the beginning, there is no role of a serial measurement of a uterine artery Doppler as far as management of FGR is concerned. Now again, as far as protocols are concerned, there are many, and a lot of them do not agree on a lot of things. But these are the two main protocols which probably have the most following. I, in my practice, follow the first one, which is what comes from the Barcelona group. It is, to me, very unambiguous with very clear-cut endpoints. And so the next things that I'm going to discuss is mainly going to be based on the Barcelona protocol. Both these papers are free and available online. Barcelona also has a website where you can go to their website, literally enter the weights, enter the centiles, and it will give you what next to do based on their own protocol, and this is completely free. So how do we define FGR after all of this? So they asked experts around the world, and this is the consensus that they came to. Once a fetus is less than 10 centile, then you look at other things. Less than 10 centile and less than 32 weeks. So early onset में less than 10 centile with all Dopplers normal, uterine, umbilical, MCA, DV, that's SGA. Less than 10 centile with even one Doppler abnormal, either uterine, MCA, then it's growth restriction. However, if the baby is very small, if it is less than 3 centile, then we just simply label it as FGR. We do not give it that, even if the Dopplers are normal, just the very fact that the baby is so small, it is growth restricted. So this is the definition as far as the early onset is concerned. As far as late onset is concerned, something similar with just one addition. Less than 3rd centile, definitely growth restriction. These babies do not get called as SGA babies. Between the 3rd and the 2nd centile, okay, 2 out of these 3 criteria. Either the weight is less than 10 centile, or if you have a follow-up growth chart and you find a massive drop in their growth, more than 50 centiles, okay. Crossing 2 quartiles is 50 centiles. So 75 centile growth became 20 centile growth, that also gets added. And third, either a CPR less than 5 or an umbilical artery more than 95th centile or a uterine artery Doppler mean PI which is more than 95. So any Doppler abnormality, FGR. Baby less than 3rd centile, FGR. Between 3rd and 10th centile, all Dopplers normal, small for growth, small for gestation age. So to put it the other way around, a baby is small for dates if and only if its weight is between the 3rd and the 10th centile, and if it has maintained interval growth with previous scans, and if all the Dopplers are normal. That is how you label a small for dates baby. This is obviously after checking dates and ruling out a abnormal anatomy. Having gone through this, now how do we manage these babies? We've defined them. We've defined our SGAs, we've defined our growth restrictions. Now what? How do we stage them? How do we manage them? This protocol is based on the Barcelona protocol. So if we have a small fetus, which is what I just defined, between 3 and 10 centile with normal Dopplers, since these babies are at not increased risk of any adverse perineal outcomes, what we need to do is 2 weekly growth scans and Dopplers, and we can take them till full dates, till 40 weeks. Okay? The reason for 2 weekly Dopplers is we need to be sure that none of those parameters are worsening. Growth is an ongoing process. So 2 weekly Doppler because we need to be sure that till the end the Dopplers are normal, till the end the growth is not going below the 3rd centile. What about stage 1? Stage 1 FGR is the first stage, the least, where how do you define it? Either the weight less than 3rd centile with all normal Dopplers, or weight between the 3rd and 10th centile with an abnormal Doppler, but where the umbilical still has a positive end diastolic flow. So high umbilical, high MCA PI, low CPR, DV abnormalities obviously, all of this, sorry, not DV, high umbilical and positive end diastolic flow, all of this is stage 1 growth restriction. These babies are either very small or they have only mild placental insufficiency. We are saying mild because umbilical still has a positive end diastolic flow. What do these babies need? The guideline is to follow them weekly. Do we need to do everything weekly? The answer is no. Every week we just do AFI and Doppler. Every alternate week, we do the estimated weight. So growth scan fully every 2 weeks, but weekly AFI and Doppler, this is how we keep chart of their follow-up. When do we deliver? We deliver them the moment they reach term. The moment it is grade 1, stage 1 FGR and the pregnancy has reached 37 weeks, we deliver them. Mode of delivery, so far these babies can be given induction and trial of labor. They have a higher chance of that particular induction resulting in a cesarean, but so far the guidelines do not say direct cesarean delivery for these set of babies. Of course, other obstetric factors taken into account. Now we move on to the next stage of severity, which is a much severe case of placental insufficiency. Here what do we see? We see absent end diastolic flow in the umbilical artery. Like I said, because umbilical has serial deterioration, that is the vessel which is most helpful for staging. Absent end diastolic flow in the umbilical, but the ductus venosus is still normal. There are no abnormalities. So the severity is not so much that the fetus is anywhere nearing cardiac decomposition. How do we follow up such babies? We need to follow and do Dopplers every 2 to 3 days. And we try to take them as close to 34 weeks or at least 32 weeks. So absent end diastolic flow in the subgroup of patients who are willing for a regular follow-up can be carried till 32 to 34 weeks. Now I understand that everybody thinks of the cost. My patient is not going to pay for so many scans. Maybe what you can tell the patient is, for every 1 day that the baby continues to be in the uterus, there is a 2% chance of improvement in the NICU. So by paying a few thousands now, they're probably saving some lakhs for the NICU cost. So if you compare the two, it wins hands down. I mean, and like I said, we just need to do AFI Doppler every second or third day. We don't need to do the whole scan, so something can be arranged. But we can carry these babies till 32 weeks, provided other obstetric factors are fine. Stage 3 is a much more severe stage. It's a state of advanced deterioration where the placental resistance is so bad that there is a reversal in the umbilical artery seen in the fetus. Or ductus venosus has started showing early changes, where the PI of the ductus venosus is now more than the 95th centile. These babies have a very high risk of stillbirth, which means that they need even more closer monitoring, 24 to 48 hourly, and you can maximum carry them till 30 weeks. We can, and these weeks are again arrived at by various evidence of comparing continuing versus non-continuing and the outcomes in both of these babies postnatally. So reversed end diastolic flow, again, if they are willing for a close follow-up, can be carried till 30 weeks. Stage 4 FGR is the last stage where now the ductus venosus has either had an absent A wave or a reversal. This is a stage of imminent death. So if you think that you're conserving and at this point in time you're seeing ductus venosus changes, and according to your local protocols, if the baby has reached viability, then deliver. Again, you have time for deliver under Maxwell steroid cover, and from stage 2 onwards, elective LSCS is the way to go. So basically, protocol-based management is the only treatment of FGR that we have available now. And if you follow the Barcelona protocol, no case of FGR goes beyond 37 weeks. Even stage 1 with mild Doppler changes, or stage 1 where just there's a uterine artery abnormality where the baby is less than 10 centile, they advocate delivery by 37 weeks. So again, in practice, there is not much gain by pulling these FGRs till 38 weeks and 39 weeks, because sometimes the hypoxia, the brain stem's response to hypoxia can be severe, and we've seen cases of IUD even overnight while we were waiting for a induction the next morning. If you see, so far in the protocol, oligohydramnios does not feature. I have looked at 2-3 other protocols, none of them really mention oligo. How we deal with it in our practice is something you'll have to discuss with your fetal medicine. The other thing which I have not mentioned is when you are following up these babies, in these studies there was a backup of a computerized CTG, which we don't have the advantage of. So even though they are on this Doppler follow-up, an additional follow-up in the form of an NST, where you look for decelerations, because our NSTs are not very good for short-term variability, and a BPP simultaneously would be an added layer of protection and an added layer of follow-up which we have for these babies. Aluminum infusions, admission and rest, oxygen, left lateral position, none of this have had any proven benefit on FGR. The only thing that is benefited is protocol-based management. and obviously obstetric decisions take a priority. Having seen this, quickly I will just apply what we've learned to how we manage cases. So a primary gravida who's had all normal scans is referred at 26 weeks for a suspicion of a small baby. So what do? We look at scans. If you see, the weight here is at the 5th centile, what I've circled. And if you look at the Dopplers, I'm only showing the fetal Dopplers, but even the uterine artery Dopplers were all normal. So here, the weight is between the 3rd and the 10th centile with all normal Dopplers. So this baby obviously gets labeled as small for dates. And so once we get labeled as small for dates, this is the Barcelona protocol. How do you follow up a small for date baby? By 2 weekly scans and delivery at 40 weeks. So this is how the follow-up would look like. We follow up 2 weekly, generally these babies also maintain their growth curve and you deliver at 40 weeks if the situation remains the same. Next case, you have a 35-year-old primary gravida who did not come to you in the first trimester, directly comes in the second trimester where the anomaly scan is normal but you have a high uterine. At anomaly scan, there is not much that you can do for that high uterine. Aspirin has no role after 16 weeks. And this patient then develops preeclampsia at 25 weeks. And when we do the growth scan at 29 weeks, this is what we see. Weight is less than the 5th centile and Dopplers umbilical shows absent end diastolic flow, MCA is normal, ductus venosus is normal. So how do we label? This is definitely less than 10th centile with Doppler abnormalities. So not SGA, it is FGR. Now we look at the umbilical. Absent flow means it is stage 2. Stage 2 because the DV is also still normal. So this is stage 2 FGR. So how do we manage stage 2 FGR? Every 2 to 3 days we need to scan them and try to take them till 34 weeks or at least till 32 weeks. So this is how the follow-up would look like. Where if you see the dots on the Doppler graph are a lot more because every 2 to 3 days you only do the Doppler, you do the weight every 2 weeks. This baby gives you enough time for steroids, Maxulf and making all preparations that you need to make. And the final case is again a low risk of G2A1, low risk on FTS, anatomy normal, growth scan normal at 28 weeks. And then at 35 weeks, you get a growth pattern which is like this. So the weight is 9th centile. And this is the Doppler. The umbilical is normal, but the MCA PI is low and the CPR is also low. So because we have a Doppler abnormality, even though the weight is on the 9th centile, this is definitely a growth restriction. Since it's 35 weeks, it is late onset growth restriction. Since the umbilical is, since it's just low CPR, umbilical is positive end diastolic flow. This is stage 1 late onset growth restriction. And how do we manage? We manage them by weekly scans and delivery by 37 weeks. So she was 35 weeks, you see her weekly in addition to NSTs and BPPs, and then the moment she's 37 weeks, you deliver. So to summarize, ultrasound and Doppler are the mainstay for management of growth restriction. First goal is to identify the SGAs who usually do not give us trouble even after birth. Second goal, once you've diagnosed an FGR, you stage it, and then once you stage it, you follow a protocol and deliver as per that protocol. Thank you.
Thank you, Dr. Shetal, for your excellent lecture covering a huge topic so precisely in a short time. Thank you very much.
I request, please, all the chairpersons come on dais for felicitation of Dr. Shetal Mehta, ma'am. Dr. Milind Shah, sir. Dr. Rohini, ma'am, please join. Monica, please.
See, as I told you, Sumit, the same way Monica. Monica saying Shetal is going to come. And then I said, okay, too.
I request Dr. Milind Shah, sir, to felicitate our first chairperson, Dr. Smita Patil, ma'am. I request Dr. Rohini Deshpande ma'am to please felicitate Dr. Meena Jinturkar ma'am.
I request Milin Shah sir, please felicitate Dr. Sudesh Doshi sir.
Thank you, everyone. We now move forward to